Welcome to our video on macrovascular complications and infections in diabetes. Let's begin. In this lecture on macrovascular complications of diabetes, we will cover the general information, pathogenesis, clinical manifestations, and management. We will also briefly cover infections and diabetes. There is an increased incidence of cardiovascular, cerebrovascular, and peripheral artery disease in patients with diabetes mellitus. In fact, diabetic patients are 2 to 4 times more likely to die from heart disease than the general population. Additionally, more than 70% of deaths in diabetes are due to coronary heart disease. This should give you an idea about the significance of these macrovascular complications in diabetes and how important it is to minimize their occurrence. Now let's discuss the pathogenesis of these macrovascular complications. The major pathogenic factor is accelerated atherosclerosis. Patients with diabetes not only develop atherosclerosis earlier than the general population, but also the atherosclerosis tends to be more severe and extensive. This predisposes them to organ ischemia, which we will discuss further in our clinical manifestations section of the lecture. It is also important to realize the diabetes potentiates the effects of other risk factors for atherosclerosis. Let's take a further look at this one on the next slide. Diabetes accelerates atherosclerosis because patients with diabetes, especially type 2, usually have other atherosclerotic risk factors as well, such as hypertension, obesity, and dyslipidemia. Diabetes potentiates the effect of these risk factors on the cardiovascular system. This increases the chance of ischemia in organs such as heart, brain, and extremities, leading to coronary artery disease, stroke, and peripheral artery disease, respectively. Although there is also an independent toxic effect of hyperglycemia on the vessels and cardiac muscle, strict glycemic control hasn't shown much benefit in reducing the risk of these complications. Hence, the most effective way to manage the macrovascular disease is to identify and treat other cardiovascular risk factors such as smoking, hypertension, and obesity, in addition to glycemic control. Macrovascular disease can present in a number of ways, most commonly as coronary artery disease, including myocardial infarction, stroke, and peripheral artery disease. Let's discuss coronary artery disease first. Typical symptoms of an acute coronary syndrome, secondary to coronary artery disease, such as chest pain, dyspnea, and diaphoresis, may or may not be present. Instead, patients with diabetes frequently suffer from silent myocardial infarctions, in which only vague symptoms such as nausea and fatigue are present. Here you can see that when a coronary artery is blocked, then the patient gets a feeling of severe chest pain and tightness due to heart attack. Remember that patients with diabetes are 2 to 4 times more likely to die from cardiovascular disease than the general population, and that they may not present with the classic signs of an MI, such as chest tightness or pain. Stroke in a diabetic patient typically presents the same way as it does in the general population, with signs such as sudden onset hemiplegia and aphasia, among many others. Similarly to coronary artery disease, the typical symptoms of peripheral artery disease, such as intermittent claudication and rest pain, may not occur in some diabetic patients due to diabetic neuropathy. Here's an image showing numerous ulcers on a patient's foot. These are formed due to ischemia as a result of peripheral artery disease. Notice that these ulcers are on the top of the foot, which are more consistent with peripheral artery disease secondary to diabetes mellitus. However, patients with diabetes may also develop ulcers on the bottom of their feet secondary to peripheral neuropathy. Now, let's discuss the preventative management for macrovascular disease in diabetics. As we've said previously, the best way to prevent macrovascular disease is by identifying and treating other cardiovascular risk factors, in addition to glycemic control. The target hemoglobin A1C is less than 7%, which is accomplished by appropriate insulin or oral glycemic therapy and lifestyle modifications, which are crucial in controlling other risk factors such as hypertension and obesity. The patient should also be advised to control their diet, exercise daily, stop smoking if they smoke, and reduce their weight if they're obese. Blood pressure should be checked at every visit, and antihypertensive medications should be started if the blood pressure is above 130/80. Note that the target blood pressure is lower than that in the general population, which has 140/90 as their target blood pressure. ACE inhibitors, or angiotensin II receptor blockers, are the first-line agents in those with diabetes, as these have renoprotective activity in addition to their antihypertensive activity. An annual lipid profile is done and statins prescribed if the patient's LDL is more than 100. Note that this target LDL of 100 is lower than the general population, in which an LDL of 130 to 160 is acceptable, depending on the presence of various cardiovascular risk factors. Lastly, since diabetes is considered a coronary heart disease risk equivalent by most groups, a daily dose of aspirin is generally prescribed in all patients older than 30, unless contraindications exist, to reduce the risk of cardiovascular and cerebrovascular accidents. What is the first-line antihypertensive drug in patients with hypertension and diabetes mellitus, and why? The first-line antihypertensive agent in diabetic patients is angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers. This is because all diabetic patients are at risk of developing nephropathy, and these drugs, in addition to lowering blood pressure, are renoprotective. Now let's briefly discuss infections in diabetes. You need to remember that diabetic patients are in an immunocompromised state. This is because diabetes causes poor white blood cell function. In addition, Candida species thrive in high glucose concentrations, and therefore diabetic women will frequently develop vaginal candidiasis. So the infections we see more commonly in diabetic patients are oral and vaginal candidiasis, pneumonia, malignant otitis externa, and rhinocerebral mucormycosis. Rhinocerebral mucormycosis is particularly associated with diabetic ketoacidosis. Here's an image depicting the various infectious lesions which are more commonly seen in diabetics. The topmost lesion is that of mucormycosis. You can appreciate the extensive tissue necrosis near nose and orbit. Remember that mucormycosis typically occurs after a patient has had an episode of diabetic ketoacidosis. The left image shows oropharyngeal candidiasis, which is also known as oral thrush. A white-colored plaque resembling a pseudomembrane can be appreciated. And finally, the right one represents otitis externa. You can observe the red, swollen necrotic area in the external auditory canal. This most commonly occurs due to infection by Pseudomonas aeruginosa. All patients with diabetes need an annual influenza vaccination and pneumococcal vaccination. Adults less than 65 years old require the pneumococcal polysaccharide vaccine alone. Adults older than 65 are given the sequential pneumococcal conjugate vaccine followed by the polysaccharide vaccine. Let's end our lecture with a board-style question. A 57-year-old man comes to the physician for an annual health maintenance examination in October. He has a past medical history of type 2 diabetes mellitus and hypertension with managed lifestyle modifications, metformin and enalapril. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 145/95, heart rate of 78, and respiratory rate of 15. The physical examination is unremarkable. The patient asks if he needs to receive any vaccinations. Which of the following vaccinations is the patient currently eligible for? A. Influenza vaccine. B. Influenza and PPSV23 vaccines. C. PCV13 vaccine. Or D. Influenza and PCV13 vaccines. This 57-year-old man has a past medical history of type 2 diabetes mellitus and hypertension managed with lifestyle modifications, metformin, and enalapril. The patient asks if he needs to receive any vaccinations. Since he presents in the fall, he needs to receive influenza vaccine. Additionally, since he has diabetes and he's under 65, he's eligible for PPSV23 vaccine. Therefore, the correct answer is option B. Here's a slide reminding us of the vaccinations necessary for diabetics. Pause the video and consider this slide once more. Let's discuss why other options are incorrect. Option A is incorrect because diabetic patients under 65 need to get PPSV23 vaccine in addition to the influenza vaccine. Options C and D are incorrect because diabetic patients are supposed to receive the PCV13 vaccine after the age of 65. And that concludes our lecture on macrovascular complications and infections in diabetes.